Hello everyone and welcome to today's kitchen session, supporting young men with depression, delivered by Professor Alan Finnegan, who is Director of Westminster Centre for Research and Veterans. Apologies for the slight delay in starting the presentation, we've had a few technical hitches. My name is Mark and I'm a HE advisor here at the University of Chester. I'm here along with Alex and Katie today, who are both helping behind the scenes. I'll start by ensuring you that your video and audio are not shared at all during the course of this session. In terms of how today will work, I will shortly be handed over to Alan. During the presentation, you'll be able to ask questions in the chat function on the right-hand side of the screen. You can ask questions anonymously if you wish. You just need to tick the box to say that you wish to be anonymous. You can also like your other questions that people may have asked and answer any questions that Alan may ask by responding in the chat function. Katie will ask the questions at the end of the session. So I think that's everything for now. Over to you, Alan, to start your presentation.
Okay, next slide, please. Okay, that's working. Hopefully everyone can see that. We've had some technical issues, and you'll see I spent minutes putting these slides together, so I really needed them at some point of reference. I'm Alan Finnegan. I'm the Professor of Nursing here at University of Chester, and I'm going to do a quick run through supporting young men with depression. Next slide, please. So my background is I spent 30 years in the British Armed Forces, part of the Defence Medical Services mental health teams. And the Armed Forces, not surprisingly, is made up of predominantly young men. So my role within inside that Occupational Health Service was trying to keep these young soldiers fit and healthy and ready to go on operations and deploy as needed. Now, the support of young soldiers, some things have stayed remarkably the same. Many enlist from areas which are quite deprived and disadvantaged. They join up for a livelihood, and as Wellington said a couple of hundred years ago at the Battle of Waterloo, he listed them as the scum of the earth, those who enlisted solely for drink. You know, these young men traditionally were cannon fodder. They were meant to survive, they were meant to be flexible, and they were meant to get on with it. But at times of need, they stood up. And the second photo there is, I'm not sure how clear it is, but it's meant to be a depiction of the charge of the Light Brigade, which is 50 years on at the Crimean. And there, Lord Tennyson, poem where he said that theirs is not a reason why, theirs is but to do or die into the valley of death, rode the 600. And it was this kind of narrative which projected these service personnel, these young men, at times of need, into be a real focus of what society needs to do for them. Next slide, please. The part of the thing about Tennyson's poem that was correlated to it was the Crimean was the first time that war correspondents had deployed with the armed forces to depict what they saw on the ground. And one of the things which they saw on the ground, which was reported by William Howard Russell in the Times newspaper, was a medical facilities that were appalling. They were fundamentally a pest house. The orderlies who cared for these injured service personnel were sometimes under the kind of supervision of a regimental surgeon, but more times than not, they weren't too much good for anything else. The women that were there tended to be the soldiers' wives. They moved with them, the camp followers. But looking after people, looking after soldiers, was seen as being something lower than the low. But when Russell gave this picture of how poor things were, it's motivated the country, and the country then motivated the government to look at a way of making this better. The War Secretary at the time, Sidney Herbert, turned to a family he knew well, the Nightingales, and Florence, who had been named after the city of her birth in Italy, was deployed to the Crimea, and she was given full control over trying to address and support and give better care to the service personnel, and also to be hands-on in relation to making things just generally better. Now, Nightingale's approach was, first of all, she was a bit of an auditor, and we know now with COVID and what have you that getting data is really important. And Nightingale noted that up to 10 times more people were dying of things such as yellow fever, dysentery, cholera, and tuberculosis than they were dying of their ward wounds. So her approach at the time, and this will also probably strike resonance, was to these pavilion wards where the emphasis was on sanitation, cleanliness, order, beds separated from each other, open windows, ventilation. And with that in mind, we were able to halve the amount of service personnel who were dying. So the first message from looking after young people is learning lessons from the battlefield can have benefits for all. Next slide, please. But we're not really onto depression. That'll come in a slide or two. But the next aspect was in relation to, we push it forward to just over 100 years ago. And then we asked the question then about, but what about the mental health support of these young people? Well, in the First World War in 1914, the average age of a man in this country was 48. Everyone was quite young. We've nearly doubled in 100 years. Well, we've gone up to 79 anyway. But these young people were, the optimism abated. They went off to war with the general feeling that they'd be back by Christmas. But mental health generally across the world was one of low importance. Freud and Brewer had started some of their psychoanalytical work with inside Europe, but the idea that we were going to offer mental health support to these young service personnel was just not a high priority. But what we did see through the technology of the First World War is that you couldn't prepare the servicemen for what came next because they hadn't been exposed to tanks. Chemical weapons were meant to be banned. The introduction of mines and explosives and mortars was a new technology applied to trying to ruin these people's lives. And the mental health impact of this became pretty prevalent pretty quickly. So by 1914, Eliot had noted that the service personnel under continuous bombardment starting to show significant signs of mental health problems. We had this issue of the 1,000-year stare. And by the next year, Myers had coined a term called shell shock, which still strikes resonance today. And it became pretty clear that the war would be lost unless the mental health support of these service personnel was rapidly addressed. And the principles of military psychiatry, which remain the principles of many crisis intervention models, was one of what we call PI. The service personnel were treated in the proximity of where they were. They weren't evacuated away from the front line. Although they were given some respite, they'd be taken slightly back, but they weren't evacuated from theatre. They were given immediate support, and they were given support with the expectation that they would get better. And some of the early models that were introduced around 1914, 1915, I think have got great resonance today. There was a motivation to get people to use common sense, to use diversion therapies. The bottom picture there shows what was a bath company. That's a job I wouldn't have minded, actually, driving around the place giving out baths. But the idea was that people could just take some respite. And the issue from that was that by the end of the First World War, the models that we now see in mental health traditionally throughout the, not just the UK, throughout the world, things such as crisis intervention, such as group psychotherapies, such as trauma-focused cognitive behavioural therapies, have their antecedents in the First World War. Next slide, please. Well, so what? We're 100 years. We're 100 years on, and the world has changed for many. But without being contentious, for some of the areas where service personnel come from, they're still quite hard areas. They're areas of deprivation, and they're challenging. And in these areas, it's still to a certain degree that boys wear blue, girls wear pink, and there's an expectation on males, which sometimes they're just not prepared for. But there's an expectation that they should be resilient enough to cope. And there starts one of the first traps in relation to why they get depressed and why we need to support them. Next slide, please. Which brings us into this second part of the slide, really, in relation to, the next of the lecture of this science of depression. Well, depression is a big deal. There's up to 350 million people living with depression. It's expected that maybe up to 1 in 4 people in the UK will experience depression in their lifetime, up to 1 in 20 in a year. And depression is a diagnosis that acknowledges differences based on severity and frequency. So if you go to a doctor and you were depressed, you could be classified as mild, moderate or severe. Fundamentally, it's a checklist. You go and see your GP. If there's been a significant change in your mood over a 2-week period and you hit some of these characteristics such as losing weight or sleep deprivation, then you're going to be depressed. I hate the term mild depression because it indicates that the person's condition may not be significant, and mild depression can be significant. But there are other issues in relation to depression. It means different things to different people. So it can be exacerbated also by borderline cases. We talk about comorbidity. So if someone's also drinking or they're taking drugs in tandem with these lifetime stresses which are going on, then they're more likely to be depressed. And then there are other reasons for depression. So what I'm going to focus on in the last few minutes is over what we would call situational stresses. We'll all get a feel for those once I start talking about them, but that's not to negate that depression can be due to biological reasons. It can be a disorder such as ineffective neurotransmitter activity. There could be cerebrovascular diseases or physical health. And then there's a cognitive triad based around those people who have negative thoughts and their person's perception can trigger the problem. But the issues I'm going to talk about really to a large degree, next slide please, would be situational stresses. And when you're dealing with someone and you want to support someone who is depressed, there's certain things you need to identify. And those are to a certain degree, what is making that person's life poor? And right at the top of that list often is unemployment and relationship problems and family problems. And if you put into the mix anything in relation to their housing or occupational stresses at work, and all of a sudden you get a cocktail where it becomes quite easy to identify that the more stresses you have, the more problems you have. But it's this cocktail of problems and the fact that depression means different things to different people that causes a lot of difficulty in relation to someone if they go to support from their GP. As depression from a Lancet meta-analysis is missed in over 50 times of the presentation of inside primary healthcare practice. So what can we be doing to look out for? If I was talking to people from a charity or from a self-help group or from a clinical background, what could we ask to look out for? Next slide, please. And I'm just going to link you back in for a final slide of what we did with the military. This was important to the military. We looked at all of our patients going into hospital over a 3-year period, and the #1 cause of hospital admissions with service personnel was for depression. And it therefore became important in an occupational organisation where keeping people off the front line still means an inability to function, that we looked at exactly what were the causes for this depression. And whilst this is in a military context, it definitely has transferability over to civilian platform. And the 4 things that came out was, 1, you need to identify the situational stresses that the individual's going through. Communication is a great thing, and you can find out if people have got relationship issues and family issues or occupational stresses. We also found out that in the armed forces, that if you have one major lifetime experience, then you're likely to function. But it's like a glass. If you keep pouring enough water into it, it's going to go over the top. And the more problems you get there, but for the grace of God you are going to have issues. But to help them, you also need to work out, are there other issues which are playing a part in this? And a major cause of depression always can be physical issues. Anyone who knows people who've had chronic pain, their life isn't good. So you need to work out if there's physical issues. You also need to work out how that person is adapting to the changes in their environment. And if it's drinking huge amounts of alcohol, it's probably not too good. If it's going for a run once a day and doing a good run and a bit of exercise and doing some proactive, it's pretty much an awful lot better, which is another one of those messages we hear at present between the COVID element. You all stay at home, would you get out once a day and do some exercise? It's a counter between the two, but definitely in an armed forces perspective, we promoted positive coping mechanisms and moved away from things such as substance abuse or isolation or alcohol. And then the one trigger which becomes an important aspect for all of us is in relation to how do we get help-seeking behaviour into people who traditionally avoid seeking support. And if you don't go and seek support from your doctor, or you can't go and get support from your friends, how do you make sure that that person can get the support that they get? Next slide, please. I've just got 3 slides to go. The other aspect from that research which became important is, I mentioned a few minutes ago, is that we have a tick list. And if you go into your GP and you have enough of that tick list, then you can be diagnosed and you can have the appropriate treatment. One of the aspects that came out from our research is that quite often young men present with symptoms that aren't on that tick list. They can tell you about horrendous feelings and have this emotional rigidity. There's no tears, there's no expressions, but then their behaviour can be going into fighting. Their behaviour can be taking risk-taking behaviour and drinking more than they normally do. Can be getting into the car and speeding down the motorway, and they get arrested for being bad. When what they really need is some form of significant support to make them to move them on their way. Now, the nice guidelines from our government give us some good indications of how to support people who are depressed, and I'm not going to go too far away from them, but it's a case of how you apply them. The first one is if you're not feeling well and it's a situational stressor, then the first aspects of a stepped care model is for mild depression. You do watchful waiting. So if you were to go to your GP, there's a good chance that, unless you've got any form of suicidal ideation, is that they're likely to move you away and come back a week later and maybe give you some time off work. Or self-help, and we'll come back to self-help later. For moderate depression, they start to talk about using psychotherapists and some form of counselling. And then with severe kind of depression, you start getting into the use of drugs and psychotherapeutics again, but pharmacological interventions as well. In the military, we didn't go so much for the drugs. We tried to change the environment. We found that if you had a number of stresses in your life, if you could support 1 or 2, things got significantly better pretty quickly, and you could move on. And certainly the balance in relation to antidepressants has gone. It's up to 50% of people with depression get antidepressants, which is down maybe to the choice of the GPs, but I wouldn't advocate it immediately. Next slide, please. What can be useful, though, is when we say self-help, it's more in relation to psychoeducation and understanding that the things you're going through, you're not alone in doing that. We need a full court press on this. We need the media to keep up the positive messages, and we need these elements of social prescribing. We need people to be able to get out where possible into any kind of group interventions, which help. And again, with an armed forces perspective, if you looked in Warrington, where our campus is, you'll find Warrington Wolves have a really proactive programme with young veterans. Everton in the community of a veterans programme, and they have preferences for young men. And if you're not going to go and see your GP, for many, what they will do is go and see their sports team. And there are other forms of intervention which can be useful, such as mindfulness and yoga. And the idea is to pick something, an individual pathway that supports that individual, rather than just a blanket approach. And then the final slide, please. And it follows on from the other one to a certain degree, using role models proactively, and then looking at how you can make this person's life better. Education plays a part, but I'd say even more so is finding an employment or a niche that fits the individual that they're going to be good at. And the idea of apprenticeships and getting into some kind of this lad here looks like he's doing a bit of carpentry can be really beneficial. So with that in mind, that's my quick 20-minute spin through supporting people with depression. And there's a final slide for questions, which I'm happy to take.
Okay, so the first question that we've had sent in is, you talked a lot about the importance of getting support from family and friends.
Yeah.
When people are experiencing depression,
Yeah.
but as a friend or family member, what should they look out for?
Well, the lifetime experiences that the individual go through will probably smack them in the face. If someone loses their job or there's problems with the kids, it's probably likely to jump out with them. But it's changes, it's notable changes in mood. It's an inability just not to enjoy the things that you'd normally enjoy, and then just changes in behaviour. So obviously the thing about sleep disturbance jumps out, but it might be overeating, it might not be able to eat enough. And the other aspects I mentioned about young men is this, a tendency to lose temper, maybe getting into fights, type of behaviours which they wouldn't traditionally be in. The best way to find out though is to ask. There's nothing we invariably in mental health. It's quite often left to mental health clinicians to ask questions. You can't find out anything without asking the question. And if you do have concerns, that's the starting point. So you're looking out for changes in mood, you're looking out for changes in symptoms. And always with these things, the great thing about the internet is if you do have certain questions around these type of things, you can go out there and you can look them up. Hopefully that helps.
Thanks, Alan. Leading on to your answer to that question as well. Obviously, we all know it is important to talk and to listen to people who are suffering with these kind of mental illnesses. But how would you say is the best way to kind of approach the subject with someone who's struggling?
Well, the first point is this is quite often a slow burn, and what I mean by that, you don't just end up depressed. Your moods, it's a bit of a trajectory. Some people say that once someone's depressed or has got a depressive personality, if there is along those stresses, it's kind of like you're on a continuum. You can go one way or the other. The best way to approach it, quite often, if it's a family or friend, you'll probably know where the natural place is. So if I was to say here that, having just said avoid alcohol, if the means of getting someone to take their barriers down is to have a pint, and during half time to say, look, you're not your normal self today, anything going on, for that person, that might be the place to go. And it's why some places such as I have been involved with Everton in the community, and there quite often you've got people who are quite isolated as well. They don't have the friends we're talking about, and they go to that community, and it's almost like a little bit of permission. It's not everyone sat around talking about these things. Quite often it's around doing group activities, but you find a way and you find a place to do it. But the number one aspect we do find with these things is just not feeling comfortable to broach it. And certainly service personnel, we've heard for many a year with service personnel, it's children or grandchildren saying, my granddad or my father never told us about what happened. Quite often no one's asked them. Or if they do go out somewhere, some people tend to get bored really quickly and are more interested in what the football result was last night. It takes a bit of an investment, but once you start the conversation, traditionally they will start speaking, but there's no perfect place to do it. You'd need to know, you'd need to find that on an individual basis. But the last thing I would say there, but from a clinical perspective, it's not always in a GP surgery or a clinical setting, and therefore moving the focus away from those settings into things like sports clubs. Our evidence-based is a really good source of getting people to engage. Once they engage, they'll talk, and you can address other issues.
Yeah, I think now there is definitely a lot more conversation happening around kind of mental health, especially with kind of young men as well. It is more of a conversation, and people are starting to open up a lot more about it. But one final question before we do go back to Mark. What would you, as well as obviously talking and listening from a family friend point of view, what would you say are good coping mechanisms if you feel yourself going down, kind of feeling low moods or feeling like you said there's different levels of depression? What would you say are good coping mechanisms?
Yeah, it's what the person engages with, which they enjoy. So when you look at social prescribing, which I mentioned there briefly, social prescribing goes from archaeology to fly fishing to horseback riding to getting on a boat and going out on a boat or going canoeing or doing a run. the individual normally has something which they enjoy doing. One of the things about depression is they lose that volition, they lose that drive. So you find your way, and you find out some things that you like to do. And of course, I come from a mental health perspective. So if that was going out once or twice a week, socially, and having a couple of beers with some friends, on a social perspective, or having a £5 bet on a Saturday, because you like to have a £5 bet on a Saturday, then from my perspective, that's okay. Now, this is when the public health start jumping up and down and saying, oh, he's suddenly endorsing alcohol and gambling, which I'm not. But what I can say is that sometimes people just have their own respite. And so long as it's done in a control, in moderation, and they get enjoyment from it, then that's good. But with the situational stresses, invariably, something has to happen about the situational stressor to make it better. And that becomes difficult. So if the person has financial issues, or the person is unemployed, or the person's partner's left them because they don't want to see him anymore, then that is where you have, you're going to have to work hard, and you're going to have to stay around. You're going to have to give them the support they need, because things get better in the long term, but it doesn't feel like that at the time.
Yeah, definitely. Just in addition to that, we've had 2 more questions come through, so I will ask these 2. So these are from Yvonne, and she's asked, do you think that schools should add mental health to the curriculum as an ongoing thing?
Yeah, some schools already have, and in our faculty of health, we are working on, because this is very, very popular in the USA, it's very popular in other countries. So psychoeducation is important, and we know that mental health impacting on one member of the family impacts on all members of the family. And education in schools, for me, can only be a positive.
And the second question just there is, this is the final question we've got. How can we go about breaking gender expectations and the norms which allow young men to be open about their feelings?
This is a question that's been moving around for many years in the government's 5-year plan, looking at mental health and trying to reduce suicides. The idea of getting guys to engage, in particular, is important. One of the things which is a little bit of an issue is that when they do go for support, the thing around GP surgeries, if you can get in now, let's go pre-COVID, was that most of the appointments are only for a few minutes in time, and if the GP doesn't know the individual, they don't pick up some of the maybe telltale signs, especially what I said about the emotional rigidity. They don't tell you where it is. I think there are a lot of positive messages out there at present. I do think things have got better. If I had a concern, which probably isn't answering the question, but it is a concern that's out there, is whilst things have got better, if that individual doesn't get better after a period of time, we go back to the old stereotypes. If someone hasn't got better after 2 or 3 weeks, then they start being seen as weak or a weakling. But I do think things have probably got a little bit better for the individuals in the short term, and it's work in progress. If I had the magic wand for that one, the world would be a better place.
Thank you for sharing that, and I think a lot of people would have found that information quite useful today as well. So that is all the questions we've got for now. So if we go back to Mark, and then if anyone's got any further questions after the event, you can always send those through to us.
So that rounds things up for today's session. We hope you've enjoyed today and found it really useful. Thanks to Alan, Alex and Katie. We're running many more kitchen sessions throughout January, so please do check the schedule and sign up for any others you may be interested in. Just head over to our website, chester.ac.uk, and you should be able to find out more information over there. So thank you.